Anyway, I think I'll start, then I will catch up. The question is whether do you believe in unicondylar arthroplasty or not. When we see these two X-rays, I mean, are these apples? They are apple and oranges, and it is obvious that they are apple and oranges. So would you give the same treatment to both? I think any person with common sense will say no. Then, we saw this classification that it is not just osteoarthritis. There are various types of osteoarthritis, and there is one entity called anteromedial arthritis and posteromedial, all those things. But anteromedial arthritis is one definite entity which is there, because in this situation, if the anterior cruciate ligament is intact, it does not allow the posterior most cartilage to wear away, and therefore the medial collateral ligament does not contract. It retains its length. Whereas if ACL goes, the MCL contracts to some extent, not fully, but it does. So that is the big difference, and you would have seen sometimes when you take the cut, the posterior cortex is intact in many cases where we are doing total knee arthroplasty. So if there is bone-on-bone contact, and if the ACL and MCL are functionally intact, and if the lateral compartment is looking good, that's a very good scenario for doing partial knee arthroplasty in my book. And we don't have to do any major investigations to decide that. Only plain X-ray lateral view is enough to tell us whether ACL is intact or not. Don't need to do MRI, don't need to do arthroscopy. Even clinically one can get sometimes confused. So this is enough. And now if you look at these X-rays, are these both apples? Or they are also apples and oranges? Because in one there is bone on bone, in the other one it is the cartilage is intact to some extent, whereas the joint space is decreased. So again, this is partial thickness cartilage loss on one side and total cartilage loss on the other side. So would you treat them differently? Obviously, if you have an option, you would not. So here is a scenario where on one side you would do a high tibial osteotomy, on the other side you would do a unicondylar arthroplasty, age permitting. Whereas the concept of HTO is very different. You want to bring the Fujisawa point and the weight lining to that. On the other hand, in the partial knee arthroplasty, you are removing the diseased portion of the joint altogether. So these two are different philosophies altogether. I don't know why people always talk of HTO and unicondylar knee arthroplasty in the same breath. They are two different operations, almost two different indications. So just to sum up, I will say if it is a cartilage disease, mostly HTO. If it is a bone-on-bone disease, it is uni or total, depending on many other factors. So if there is cartilage loss, then in fact, if you go in the literature, if you do unicondylar arthroplasty, when it is not bone-on-bone, for some reason, the results are not as good as when there is bone-on-bone arthritis. So this is very clear-cut. Now this paper is so often quoted that I am tired of taking this name of Cousin and Scott, that they said that there are many places where you cannot do unicondylar arthroplasty, which is actually not true, especially with the mobile partial knee arthroplasty, weight, patellofemoral arthritis, chondrocalcinosis, all these things, it was felt that they are not true. In fact, some of these so-called not ideal indications gave actually better results than others. So all these overweight, we have done for over 110 kilo person, and it is now documented in the literature that unicondylar arthroplasty, weight is not a contraindication. Of course, the BMI should not be 40, but where you can do total, you can do partial as well. And old age, I think it's a God-sent operation for old age if you have a medial arthritis. So less morbidity, such good function, so quick recovery. I think old men actually bless you when you do partial knee when it is indicated. So there is no question the results are excellent in them and it lasts them the lifetime. In young as well, the results are excellent. As a matter of fact, the more active, the more the Turger score, the better the results. So previous contraindication of age is also out of the window as far as the mobile bearing is concerned. Then there are extended indication like Song does very well. ACL deficiency, if you do fixed bearing is excellent, or you reconstruct the ACL if the patient is relatively very young and do a mobile. But don't do mobile as per today, but probably time will come when they will say you can do mobile also in ACL deficient. Of course, and inflammatory arthropathy is a no-no for partial knee because obvious. I mean, the whole joint is affected. Why are you going to change only one part? That is common sense. And severe deformity also, common sense because it will be tricompartmental. The problem is that the unicondylar has a long learning curve relatively. That is why people shy away from this. So if you can learn how to make your cut, don't lift your hand, don't make too many holes, make sure that you don't do things that will cause tibial fracture, don't underhang, don't remove too much of bone when you're doing tibial cut, then you will prevent all these complications that people see. So that is, and the good news is, if you're doing mobile bearing, then alignment also doesn't matter so much. 10 degree here and there doesn't matter. So it's God sent for people like me. I don't have to think too much. Only the balance has to be right. Whereas in fixed bearing, your alignment, your placement, it must run over properly, otherwise it will cause bear. And robotic has now come into its own and is excellent for fixed bearing, I think. And I mean, that problem is also over. Now, if you see the results, the partial knee complications are far less compared to total knee. So when it is indicated, there is no, I mean, I have no question in mind. And if you see the results also, when you see top cat study, you see results, 10-year survival, 95%, you can see 15-year survival, 94%, 20-year survival, 91%, and 15-year survival. See, all these tell you that this is not a temporizing operation. It is not time-buying operation. It's a definite indication, definite operation, and definite survival as much as total knee arthroplasty. The problem is that this should be done by people who are doing some numbers. It's for like anything. If you're doing 500 knees a year, or if you're doing 10, even total knee you will fumble. So here in unicondylar, you should be doing at least a minimum number so that you are used to the procedure and you don't cause complications. What happens is that if you have this 20% knees which are painful, nobody says revise. But if you have a unicondylar knee which is painful, oh, he didn't do that, he didn't do patella, he didn't do lateral, he didn't do this, let's revise it. So that is why the revision rate also is little higher, not because there was a big problem, because I did not do it. I did not understand the radial-luceral lines which are always there anyway in unicondylar. So that is why the problem. And now all these some of the registry also compared results of people who do 2 or 3 or 4 unis a year and those who do 500. All they have been clubbed in one registry. So that's why it's a little skewed. And long learning curve. These are the two problems. Some people shy away from that. And gentlemen, please believe me, once you start doing uni, you will always think, why the hell am I doing total in this patient? So that's my thinking. Every time a patient walks into my chamber, I say, why can't I do uni in this? Why do I have to do total knee arthroplasty? The fact is that 49% of patients, up to 49% of patients who are getting total knee don't need total knee. They'll do better with unicondylar arthroplasty. So I will now ask you, please raise your hand, how many of you believe in uni? Still is less than 25%. I will request my other colleagues, please become a believer. Thank you very much.